Hello, my name is Saad Usmani. I am the Chief of the Myeloma Service at Memorial Sloan Kettering Cancer Center, and I'm here with blood cancer today. We are here in Chicago for the ASCO 2023 annual meeting, and we're going to be talking about all the exciting data coming out in multiple myeloma. We'll cover the newly diagnosed setting, some of the approaches to early as well as late relapses in the context of new novel immunotherapies, including bispecifics and CAR-Ts. So I'm looking forward to having a wonderful, engaging conversation with my colleagues. I'll let them introduce themselves.
Hi, I'm Yi Lin. I'm from Mayo Clinic in Rochester, Minnesota.
Hi, I'm Shambavi Richard. I'm from Mount Sinai, New York.
Hello, I'm Meera Mohan. I'm from the Medical College of Wisconsin.
In late relapse, patients who are triple class exposed or refractory, we have 3 BCMA, targeting treatments that are currently approved. But we now have, data with the KarMMa-3 trial, and the CARTITUDE-4 study is also going to be presented, at the ASCO, or has been presented at the ASCO meeting. So what are your, can you tell us a little bit about both those trials and what the patient populations were?
So the KarMMa-3 study, as we know, is a phase 3 randomized study of patients who've got 2 to 4 prior lines of therapy. The patients were randomized to ide-cel versus a physician's choice, which in the study was mainly data-based regimen, and there was also some doublet regimens as well. So we saw the progression-free survival of about 13 months with ide-cel, and the hazard ratio was about 0.49. So these are impressive results given the tough high-risk population. These are patients who've early relapse, which is functionally high risk. And it will be really exciting to see the CARTITUDE-4 results. Again, similar patient population, phase 3 study, randomizing patients who've got 1 to 3 lines of therapy to cilta-cel versus dara-PD or Velcade with pomalidomide and dexamethasone.
So, I agree with you. I think that there's a lot of excitement, and, one thing that I want to make sure that we distinguish is, the lines of treatment were different across these 2 studies, but in terms of inclusion criteria, I think there were some differences as well. So I think, with CARTITUDE, patients, who had prior dara exposure or refractoriness were not allowed on the study because, the standard of care arm, essentially was dara-based triplets, whereas it was different for the KarMMa-3 study. So, KarMMa-3, the PFS that we see, at least ide-cel is consistent. We're seeing the same PFS in late versus, this study. But what are your thoughts about that?
Yeah, I think that's a great point that you raised. I think a lot of us in the myeloma community has been talking about was very important for us to define lines of therapy, what we consider as new line of therapy. But now, in the current treatment era, we use combinations already up front. And so by the time the patients relapse, it's not a matter of how many lines, it's what are they refractory to already. And I think that's what we're seeing with the KarMMa-3 results. Everybody was hoping, the patients on KarMMa-1 had median prior, 6 prior lines of therapies. On this study, it's 3, right, 3 or 4. And so that's many lines earlier, and hopefully the T cells are less beat up, they're more fit. And should we be expecting to see maybe a longer PFS than what we saw in KarMMa-1, as much as, we can't compare across studies. But I think what we're really seeing is that there's still a good percent of those patients in KarMMa-3 that were triple penta exposed, and then still, smaller percent, but some percent of patients who are refractory. And so I think with that type of patient demographics, it is probably not as surprising that it's actually reassuring that the PFS at least held, right, in another study, in a randomized control study. And I think what we will really find out is where CAR-T gets studied in a frontline setting where patients are only exposed, let's say, to induction therapy, and they're, just coming into active myeloma. Does CAR-T perform differently there versus later lines?